Good afternoon, everybody. I'm here to present a lecture today on pathophysiology of coronavirus. In pathophysiology class, we have gone through cardiac pathophysiology, respiratory pathophysiology, and while we're now embarking on neurological pathophysiology, I thought I'd go over specifically the pathophysiology of the coronavirus. I'm talking to you today from, despite the fact that it's spring break and despite the fact that we are all away from the university, I have all of you on my mind, and I've been, clearly working with my own safety and trying to figure that out for myself, my family, and the farm here. As well as my patients, and at the same time realizing, wow, I think perhaps it would be wise to go over and actually look at the pathophysiology of what this virus and this actually disease is all about. So it'll be a refresher for a good portion of you. So, oops. Regarding the sort of just the etiology of the coronavirus is a single-stranded RNA virus. Corona, the name of corona is because it has a crown. Corona is derived from the word crown. Crown-like arrangement of glycoproteins. So those are sugar proteins on the outside, has a sugar protein coat on the outside. There are four categories or genera of coronaviruses. There are many types of coronaviruses, and the current pandemic that we know as COVID-19 is being caused by a beta category coronavirus. As you know, these coronaviruses cause all kinds of havoc in the body, but they can cause respiratory viruses or respiratory ailments, enteric or gastrointestinal distress, hepatic diseases or liver pathologies, and neurological diseases as well. All those coronaviruses can cause a number of different diseases. Coronaviruses can affect humans, and they can also infect animals. It's also been shown that some people are actually carriers of coronaviruses, and then these are what are thought to mutate and or amplify and cause common colds, upper respiratory infections, or upper respiratory infection outbreaks. In other words, they'll reactivate and amplify into an outbreak that we have, occurring, every year, as well as lower respiratory infections. Lower respiratory infections, when we talk about that, remember we're talking mostly about pneumonia. And that's especially in immunocompromised and elderly patients. Again, this is specifically COVID virus. This is not specific. This is generally coronaviruses. Other coronaviruses cause more severe type of conditions, known as SARS, severe acute respiratory syndrome, and MERS, Middle East respiratory syndrome. So those are two different severe respiratory syndromes that have much higher level of symptomatology, much higher levels of mortality. Our current outbreak is a SARS type, severe acute respiratory syndrome illness. So SARS-CoV-2, that is specifically the name of the virus that is affecting virus that is causing COVID-19. It is round or elliptical in form, and it's pleomorphic, meaning it can change, it's sort of changes form fairly easily. It is sensitive to heat and sensitive to UV light. So that's really good to know, that especially with the coming months, we are hoping that with greater light exposure and certainly greater heat exposure, we will have a decrease in the resilience of this virus. But we also know, in terms of taking care of or disinfecting, that lipid solvent, so fat soluble solvents that can help break up the membrane and destroy the virus are helpful. Those include ethers, alcohols, and then also chlorine-containing chemicals. They know, just in terms of studying the virus and actually doing nucleotide studies, breaking the virus down and looking at the nucleotide sequencing, that there is like an 89% similarity with a bat coronavirus. In other words, a coronavirus that was that originated in bats. This is the SARS-CoV-XC2, and then also a human coronavirus known as SARS-CoV. Therefore, they combine those two, and the current virus that we are naming that is associated with this current outbreak is SARS-CoV-2. And again, it may have evolved, we're not sure, may have evolved from bats and then amplified in humans, is what they're thinking. I think originally it was in Wuhan, China, and they're tracing it back to I believe, a seafood company. Again, that was the animal to human transmission, but then it got transmitted person to person after that. Glycoproteins specific to this virus, what's really interesting is there's some uniquenesses of the glycoproteins, and that they have these spikes, they're spiked glycoproteins, and those are how they attach to the host receptors, and specifically causing havoc in the lungs. And this protein has a specific subunit, which they're studying now so that they understand the makeup of this. They can actually understand how it reproduces and therefore what this virus may be susceptible to. So they're thinking that there are some antiviral drugs that they are using that could be protective against this specific virus. So in terms of what we know about COVID-19, spread human to human, generally not before symptomatic. Now this is, I want to say that this is evaluated as asymptomatic people could be transmitting this. At least at this time, they're thinking that generally people are symptomatic when they are transmitting it, but we don't know. We don't have enough testing, and therefore we're not certain. And so in that way, isolation measures are in place. Currently, we're asked to stay home here in my county in Colorado. So, and I know in Denver as well. So again, isolation measures, staying at home, staying isolated from others, because we don't know, even though it is thought that generally people are transmitting once they are symptomatic. A bit more to come on this. We're still trying to figure this out. Transmission rates, it looks like 3 to 7 days is the time, the incubation period from when a person is exposed until when they're first symptomatic. Is generally 3 to 7 days. The longest recorded, at least at the time of the publication of the study that I'm using, that was recently put out, and got the reference to that at the end here. It says that the longest duration was 12.5 days. But therefore they're saying, you know, up to 14 days should be considered that transmission would be possible. But generally we're seeing symptoms within 3 to 7 days. And generally the shortness of breath comes about 5 to 7 days, though not for young people. So dyspnea, shortness of breath, comes more for older people, between 5 and 7 days. Again, for younger people, they may not have that, and they may not have that at all. The COVID-19 or this SARS virus produces strong immune reaction, specifically increasing IL-1. So, or sorry, IL-6. So remember the interleukins, or 3 interleukins that I needed you to remember. IL-1, IL-6, and IL-10. IL-1 being fever-producing, acts on the hypothalamus. IL-6 acting on acute phase proteins in the liver, and IL-10 being anti-inflammatory. I asked you to remember those, but IL-6 is the one that seems to be increasing with this particular virus. Again, stimulates the liver to produce these acute phase proteins. And what the problem with that is, they trigger greater cytokine release, in which is sort of known as this cytokine storm, this great increase in cytokines. And so, as we've talked about in the past, what you're actually getting is an acceleration of the inflammatory process. We like inflammation. Fire is good. To inflame is to cause a fire. We want that fire to happen in the body, but too much inflammation in our knees, for example, causes destruction in the knee, and therefore we want to take anti-inflammatories in response to the inflammation, or in response to the stimulus, which might be overuse. It could be a number of things. Well, in the body, in response to the virus, we're getting an immune reaction, which you might imagine that the adaptive immune response kicks in, and we're starting to, we activate lymphocytes, etc. And that's all good. But the problem is that there's an accelerated increase in these cytokines, accelerated production of white cells, and these white cells are causing destruction, specifically in the lungs, but other tissues as well. Again, that's going to accelerate and cause multiple issues. So physical manifestations. So in terms of the manifestations, most get an uncomplicated illness, but some people are going to get and are getting moderate to severe pneumonia. Some progressing to acute respiratory distress syndrome, or ARDS, and then others progressing further to sepsis and a high risk of death. So let's go through those. In terms of uncomplicated illness, the thing that they're seeing with nearly every case is a fever, a high fever with nearly all of these cases. Sore throat is a possibility, but not always. Dry cough, again, after 5 to 7 days. Malaise is also nearly all cases of the coronavirus has this general sense of malaise, fatigue, but also muscle pain. And interestingly, I don't know why there's a grasshopper on there for conjunctivitis, but that's kind of interesting. That's what my computer decided to create. Anyway, conjunctivitis, so redness. The American Ophthalmic Association, or perhaps it's another name, but anyway, that the National Organization for the Ophthalmologists has reported that there's an increase in conjunctivitis. And there are other symptoms as well. I know if some people are having abdominal pain, and I've heard of some cases of diarrhea, etc. But generally these are symptoms and uncomfortable symptoms that most people are going to get in an uncomplicated illness. Should the disease progress, it will progress into pneumonia, anywhere from moderate to severe pneumonia, which carries with it, as you know, a shortness of breath, an increase in the breath rate, hypoxia because you're not getting oxygen in. And why aren't you getting oxygen in? Right, because you're blocking the airway. There is a exudate that fills up the alveoli, and therefore the oxygen can't go through the alveolo-capillary membrane because it can't get through the exudate that's created, the pustular substance that's created in an immune reaction, mostly by white cells, and that prevents the oxygen from getting across the alveolo-capillary membrane into the blood to perfuse the blood and therefore to perfuse the tissues. So hypoxia, we'll talk more about that. Cyanosis, I don't think I spelled that right. Cyanosis, they're seeing that more in children than they are in adults, possibly because of our coloration, because of the thicknesses of our skin, etc. Again, I talked about that fibrinous exudate obstructs the access of the air to the membrane, and therefore your VQ, your ventilation perfusion quotient, is going to go down because you don't have ventilation. You're going to have a decreased ventilation per perfusion. So initially, at least, you have blood flow, and but because you're not getting oxygen to dissolve across the membrane, you have a low ventilation, so a low VQ ratio, as we've talked about. Over time, though, what's going to happen is, because of the pulmonary edema, you're going to see congestion in the vasculature. The pulmonary vasculature, it's just going to back up, and that's going to cause pressure on the right side of the heart. Why the right side? Because blood goes from the right side into the lungs, from the lungs into the left side, from the left side out. And so it will back up depending on the pathology, but our issue is in the lungs. The viral infection does affect the lungs, and since the lungs pathology is the issue, we've got cor pulmonale, or right heart failure, secondary to this pulmonary hypertension that gets created. Does that make sense? I think we've talked about that quite a bit. I hope that makes sense to you. Then we also see a hyperplasia of the pneumocytes. These are the type 2 pneumocytes. And what that indicates is that there is damage to the lung cells, damage to the lungs, and therefore your body, remember, in long-term, in chronic inflammation, you're going to get repair in regeneration. So with that increase in the pneumocytes, it's indicating that your lungs are trying to repair. It's actually a measure of destruction with a compensation of trying to repair. And then it has been seen an increase in these the pathology reports, an increase in the number of multinucleated giant cells. Remember from studying the immune system, what those are macrophages, or the Pac-men, that go around and scavenge. Well, what happens is they fuse. They fuse and they become bigger. Sort of like, I don't know, I think in the game Pac-Man that happens. I'm not a video connoisseur, but I think what happens is that they go along and they phagocytize, or they eat up a bunch of the other little dots or whatever, and they can puff up. And that's exactly what happens with a multinucleated giant cell. And they're seeing those secondary on autopsy. They're seeing some of that, some of those cells in the lung tissue. So that's what happens in terms of some of that pneumonia. When that pneumonia gets significant, you're going to have a significant drop in hypoxia, a decreased ability to ventilate the lungs, and therefore to perfuse the tissues. And so this is going to cause a rapid or pulmonary failure on the part of the respiratory system. So you're going to have, or if you remember, this is directly from our PowerPoint from my lecture, a diffuse alveolo-capillary membrane injury. So throughout the lungs, you're going to get damage to the alveolo-capillary membrane, the membrane that exists between the alveoli and the capillaries that's going to carry the oxygen to where it needs to go. Well, you're going to have damage of that tissue, and therefore you're not going to be able to perfuse to get oxygen into the bloodstream. So you also get injury to the capillary endothelium. And remember, we've talked about this. When you have damage to any endothelium, what happens? Platelet activation and clotting. We don't want that. That can happen in the heart as well. Remember, in the coronary vessels, secondary to atherosclerosis, when you have a complicated plaque, you have damage to the endothelium and it clots, it obstructs a coronary artery, and you have a heart attack. Well, the same thing happens here in the lungs, where you have injury to the capillary endothelium. That's going to cause platelet activation and clotting within the lungs, and therefore you are going to cause congestion or increase the pulmonary blood pressure or pulmonary hypertension, again, putting pressure on that right side of the heart. In addition, we see inactivation of the surfactant. Remember, surfactant is what holds those alveoli open and keeps their compliance so that they're actually nice and rubbery, I guess, so that they're able to inflate, but they have enough structure that they can actually push back. Without that, you have loss of that compliance, and that alveoli will collapse in a process we know as atelectasis. We've talked about that. When you have significant atelectasis, remember, the body realizes, hey, I'm not getting any ventilation. I'm going to shunt the blood elsewhere. And so you have major shunting happening in a situation because we have a very low VQ. And remember, we said that shunting happens in the case of a very low ventilation perfusion ratio. Now, the hard part with ARDS, actually this along with the next couple of slides, so buckle in here. I think you remember this, but this is where you can start to see it gets systemic. With hypoxia, a decrease in oxygenation, what's going to happen is our body, our brain, our receptors are all saying, not enough oxygen, I need you to increase your ventilations. So we start to breathe more, okay? We start into what might even be called Kussmaul respirations. As a result, not only are we trying to take in more oxygen, but we're going to be blowing off our CO2. When we blow off our CO2, we're going to end up with a respiratory cause acid-base balance known as respiratory alkalosis. Respiratory alkalosis then leads to a decrease in the perfusion. So you have a loss of perfusion, and therefore you're going to get infarcts or at least slight tissue damage, cell damage in the organs. And then what that's going to cause in the body is an increase in the production of acids in the tissues, known as metabolic acidosis. That metabolic acidosis, or compensation for that, is our lungs. Well, our lungs are problematic. That was what caused the initial issue, the respiratory acid-base balance. But now we have a metabolic acidosis, and so our lungs are going to try to compensate by blowing off, but they can't do that, and so you end up with a hypoventilation. With an increased work of breathing, you're going to use your accessory muscles you're going to have a decrease in the tidal volume because it's failing. It can't keep up because the pathology is in the lungs. The lungs cannot compensate, leading to respiratory acidosis, because again, you're not able to, the lungs aren't functioning, they're not blowing off CO2 over time. Now they're going to become acidotic, so you're going to get respiratory acidosis, and then that's going to lead to further hypoxemia, decrease in oxygenation of the blood. You're going to get a low blood pressure, and because your heart is working too hard to compensate here, you're going to end up with cardiomyopathy or damage to the heart muscle. Again, any kind of damage, we're going to have an increase in CKMB, creatine kinase MB, specifically to the heart. So there's going to be a release in enzymes when you have damage to the heart muscle, and you're also going to have an increase in troponin. Troponin is a protein in the heart muscle which helps with the contractions. Well, you're going to have damage to the heart muscle, therefore you have that troponin all leaving and getting into the blood. You now measure the blood, you have an increase in troponin, telling us that the heart muscles are being destroyed. Again, over time that leads to cardiac output and cardiac failure, and possibly resulting in death. Remember that this is a multi-faceted issue, acute respiratory stress is. So you have this pneumonia. It can be caused by a number of things, aspirations, inhalations, various things, we know that. But then you get this release of cytokines, as we talked about, specifically in COVID, it seems to be the IL-6, an influx of inflammatory cells into the lungs, which, yay, you would normally want that. The problem is we're getting too many of them and they're going to cause damage. You get a release of reactive oxygen species, so free radicals get released, and other systems come into play as well, in addition to cytokines, such as the complement system. So that entire inflammatory response gets engaged and is creating a response and actually causing damage. So again, damage to the type 2 pneumocytes, which is going to lead to collapse of the lungs, atelectasis, a disruption of the alveolar capillary membrane, we talked about, and ending up in shunting. You're going to get microthrombi secondary to damage to the endothelium, and that's going to increase pulmonary blood pressure and causing pulmonary hypertension. And then again, a release of fibroblast growth, so that's going to cause fibrosis. You're going to actually have scar tissue. That's going to be a little bit more long-term if you get, further into the process, because remember that fibroblasts are an indicator of chronic inflammation. Further beyond ARDS, a person may progress into sepsis. We've talked a little bit about sepsis, but sepsis happens as a result of a dysregulated host response. In other words, our body is not able to respond appropriately and systematically, and resulting in the respiratory manifestations that we just talked about. Your kidneys will start to fail. You'll have a decrease in the renal output. Tachycardia, your heart's going to go, is going to accelerate again because it's not keeping up. Altered mental status happens. The person's going to lose consciousness at one end of things, going into a comatose state perhaps. And then septic shock. Certainly, septic shock would lead to significant issues. But remember what shock is. Shock is when we're trying to perfuse the tissues and all of the blood vessels are vasodilated. So it's sort of like turning on all the fire hydrants at one time. You're going to have low pressure, or turning on all the showers in the house at one time, and therefore all the showers are going to have very low pressure. So in other words, none of the tissues is getting adequately perfused because everything is vasodilated, and so the pressure drops significantly. And so the goal there would be to try to increase the mean arterial pressure. This from the Chinese CDC report. Again, those are our best measures right now because, and we're starting to get some information coming out of Italy regarding their morbidity and mortality, and we don't have information coming here in the United States at this time, just small amounts, but we're not enough to really mass a good sense of what's going on. But generally, mild disease occurs in about 81% of the cases, so a significant portion of those. 8 out of 10, one might think of it. Severe disease, so shortness of breath, respiratory increase or respiratory rate, decrease in the oxygenation of the blood. This is your pneumonia, the acute respiratory distress. So that occurs in about 14% of the cases. So really, that's fairly significant. So 1 to 2, and depending on the area that you're in, depending on the demographics we're talking about, 1 to 2 out of 10 people are going to have a severe case like this. And then right now, around 5%, we're not exactly sure, will end up with respiratory failure, shock, multiple organ dysfunction. What we're really talking about is on the brink of death here. And that's certainly our worst case scenario. Okay. So hang on, I think that was my last slide, yes. So again, the references here, this is from Cascella. It's a March 2020, so it's a very current publication of a look at the coronavirus, along with some of the notes that from my pathophysiology class. Stay safe out there, stay at home, make good choices. And I hope that you come away from this having a little bit of an understanding of specifically the pathophysiology, what's actually happening as we know right now on this coronavirus. All right, I'll look forward to seeing you in class next week. Bye-bye.